So thanks very much for the opportunity to speak to you today. What I'm going to do is ask you to pretend you're on a plane flying about 9 hours south of here, and I'm going to attempt to take you on a bit of a rapid tour about the Australian primary care context and some of the work that we've been doing in the areas of clinical decision support for type 2 diabetes and chronic kidney disease. So, Australian general practice, we're recognised as a medical specialty, and Australian GPs need to have a good working knowledge of at least 167 conditions to manage 85% of our presentations. And obviously diabetes and chronic kidney disease are only a couple of those. So very different to a specialty context. Between 80 and 90% of the Australian population visit their GP at least once a year. And it's a very effective and cost-effective component of our health system. But just like many primary care systems around the world, it's facing some pretty challenging times at the moment. And that's because the costs of delivering primary care are increasing, and that's often not been accompanied by adequate funding to provide the levels of care that we really wanted to provide. And so as a result, in Australia, rates of what we call bulk billing, that's when the government covers the full cost of the consultation, are reducing. And with increasing workflow, it's becoming challenging to get junior doctors to make the decision to come into this specialty. And as a result, there's lots of changes that are occurring at the moment in terms of health policy, as there are in many other countries, which hopefully will strengthen primary care and allow that preventative medicine and holistic medicine to continue into the future. And the majority of people, and another reason why generalism is very important, is that the majority of people have multimorbidity. Now, cardiovascular multimorbidity is a subset of that, and you can see here some data that shows the interplay between chronic kidney disease, diabetes, and heart, stroke, and vascular disease, and that they're so overlapping. Now, this data is a little bit old, so really what is happening now in primary care, where in Australia, most people receive their medical care? Well, in Australia, over 90% of general practices provide their data to bodies called primary health networks that then share that with essentially the government. And they provide data on 10 quality improvement measures. Now, none currently have a focus on chronic kidney disease, so I can't show you any of those, but 3 of them actually do relate to diabetes. And what you can see is they're not really outcome measures, but they're really process measures. Now, if you have a look at these numbers, I'll be the first to agree with you that they don't look great. Immunisation status, for instance, recording in people with diabetes for influenza immunisation is quite low at 54%. But the really important thing is when it comes to a lot of these data sets is understanding, again, the context in which this data is collected. So as Juliana mentioned before, this is not registry data, this is electronic medical record data. And in Australia, we don't have patient registration, and people can access multiple different ways of accessing immunisation, such as through pharmacies or their workplace. So this doesn't really give us a really good idea of what is happening in primary care and general practice. And without a good understanding of data and all the different stakeholder views and opinions and what we want to achieve together, it's very hard to make improvement. And so learning health systems, the terminology has been around a very long time, but I think it's a bit of a buzzword in Australia, in particular at the moment, in which we can look at engaging with people, generating evidence, implementing new interventions, collecting the data to look at the impact and trying to make continual iterative improvements, both in terms of patient outcomes, but also in terms of the healthcare professionals' experience as well. So, in order to get that kind of deeper dive into data to understand general practice activity, because in many places and many countries, including Australia, it is a bit of a black box. In our department, we've set up our own data set. So we have about 130 general practices that share their electronic medical record data with us. And that represents around 1.8 million patients and many people with type 2 diabetes. And what we can do is we can then look at, all right, what are patients experiencing in terms of application of guidelines and what management are they receiving? So we have our Kidney Health Australia guidelines for chronic kidney disease management in primary care. And if we apply their guidelines, we can see that there's around a quarter of people with CKD that might benefit from optimisation of their medication management to reduce their cardiovascular disease risk. We have many different guidelines for people with type 2 diabetes. We've got RACGP guidelines, which is our College of General Practitioners. We've got guidelines from the Baker IDI, and we've got our Living Evidence Consortium guidelines as well. So lots of different guidelines for GPs to try to bring together and even know that they exist, to be fair, to look at guideline management or evidence-based management. And again, we can see that there's lots of patients just based simply on electronic medical record data that we can identify who might benefit from optimisation of management. Now, quality improvement is a word that's put around quite a lot, particularly in the primary care space. And we do know that audit and feedback as an important quality improvement measure is more likely to be effective if it's not a once-off episode, if it's reported more than once, multiple formats and action plans that are able to be personalised for different general practice settings. Because in Australia we have over 6,000 private general practices that all work individually and separately, have the different people, different cultures in there, and so they need to be able to adapt these plans to be able to suit their local context. Computerised clinical decision support isn't common in Australia. In Australia's 10-year primary care plan, they are aiming to have this embedded within Australian general practice, and ideally this should be automatic without the GP needing to do anything with patient-specific suggestions. So with all that in mind, we work together with GPs, practice nurses, practice managers and patients that attend general practice for their care to think about how we could embed clinical decision support and quality improvement in general practice with a particular focus on chronic disease. And we wanted to leverage financial incentives available through the Australian government, the long-term electronic medical record use that's already been present in Australia, but also to work with some of our hospital-based colleagues to look at working through the different guidelines that do exist and work on some consensus on what we should present to the practices. So what we came up with in the end was influenced by some initial design based on service design theory, where GPs talked about their clinical workflow, creating a prototype that was then refined with the addition of clinical decision support, and importantly also asking people with chronic disease what they thought. How did they want to be recalled back to the clinic? How would they feel if the GP was looking at their computer screen, clicking on clinical decision support? How would that make them feel? And what we created was a system where we basically turned guidelines into code, and we ran that code over the electronic medical record data in general practices every night. And then practices could log in, they could choose a condition to focus on, and here you can see an example of chronic kidney disease. And they can go all the way from looking at which people should have a kidney health check done in the first place but hadn't had one done, through to starting medications for people with chronic kidney disease that had either been diagnosed or if there was people with pathology results that were consistent with chronic kidney disease. And then if they wanted to, they could focus in just on people with type 2 diabetes who might benefit from these particular clinical actions. And then we also had, which is quite important in our setting, links to our Medicare item numbers, which were additional financial incentives for engaging with these patients. So then we could identify the patients, review their clinical records and what their pathology results, for example, were doing over time. And by the end, hopefully, we could move all the patients that needed to be reviewed from the red box at the top through to the action complete at the bottom. We could also link these to quality improvement activity plans, and these types of activities are required by GPs for their continuing professional development and their ongoing medical registration. So there was some kind of impetus in that region to get these completed. And when the patient came in, this is not a real patient, but it's an example of one of our general practice electronic medical record systems, then automatically there would be a prompt at the bottom of the screen, and if the GP or practice nurse clicked on that prompt, then they would be taken to the guidelines, but also be able to download some patient resources for patient education purposes. So these things take a while to develop, but this is a little bit of a snapshot of the activity that we undertook. So we started at the end of 2019, and then we've ended recently, or completed recently, a pragmatic cluster randomised control trial, and that's what that looked like. So we worked with 40 general practices, and we randomised 20 of them to focus on people with chronic kidney disease or pathology consistent with chronic kidney disease, because it is underdiagnosed in the electronic medical record. And we focused specifically on people who were not taking the medications that were recommended in the guidelines that you can see on the screen to reduce their cardiovascular disease risk. And then to try to fit 2 trials into one, we had an active group control where the other group didn't get any information on chronic kidney disease, but rather were focusing on people at risk of developing cancer. So the workflow kind of looked a bit like this. The practice nurse could create a cohort of patients with risk factors to try to bring them back for the GP to review. The patient would attend. During the consultation, that pop-up alert would happen, and hopefully the GP would discuss cardiovascular disease risk, lifestyle advice and prescriptions if appropriate, with the idea of, at the end, hopefully reducing the progression of chronic kidney disease to dialysis and avoiding cardiovascular disease events. So what you can see here is some characteristics of the general practices that participated in our program, and most of them were located in Victoria, which becomes very important, as I'll tell you later on. And we had quite a spread of practices, so about a third of them were in some of our most socioeconomically disadvantaged areas, and they range from rural practices through to metropolitan practices. And about half of our practices had 4 or fewer full-time equivalent GPs. So again, quite a range in the size of the general practice population as well. So overall, in those 40 practices, there represented 571,000 patients, of whom 7,500 had either a diagnosis of chronic kidney disease or pathology that was consistent with chronic kidney disease. So because our focus today is on people with type 2 diabetes and chronic kidney disease, I've just shown a subset of our patients here, so 633 patients that had their electronic medical record data included in this trial. And what you can see is, because of this combination, 96% of people were all at high cardiovascular disease risk. And you can also see at the side the chronic kidney disease stage, so mostly people at earlier stages of chronic kidney disease. Now, this is the preliminary results for the type 2 diabetes group within that chronic kidney disease cohort. And what you can see is, unfortunately, there was no difference between the intervention and control arm, which of course was very disappointing to us, and it was very similar for the overall chronic kidney disease group as well. So what you can see is that 12% of people were started on ACE inhibitors or ARBs over the 12-month period of the trial, and 13% were started on statins. So we wanted to know a little bit about why this was the case. And so we've undertaken some qualitative work in 19 of the 20 general practices that were in our chronic kidney disease arm. And we asked them some questions based on a theory called Clinical Performance Feedback Intervention Theory, or CPFit, which was developed by a GP and health informatician, Ben Brown, at the University of Manchester. And what it says is that we need to take into account, in terms of what the clinical decision support and quality improvement feedback looks like, the recipient variables, so they're our health professionals, and in the context in which the feedback was provided, and then apply that to how the GPs and nurses receive the feedback, accept it or not, and then change their behaviour perhaps as a result. So this is a very busy slide, but in some ways it's quite straightforward. So the green boxes are the boxes around the theory. So it's the different elements of the CPFit theory. And then the solid arrows are the facilitators and the dotted ones are the barriers. The good thing about diabetes and chronic kidney disease is that GPs see it as highly relevant, part of their role, easy to understand, and if they see it, they want to look at it and do something about it. But that occurs within a setting of competing priorities. So as I said, there is many different conditions. A lot of these patients that came to see their GP would have been seeing them not for chronic disease, but for other reasons. And in our system, we don't tend to have very many nurse practitioners, and so it's only GPs that can prescribe. So clinical decision support that is targeted at prescribing is obviously less actionable by them. The other thing that has a bit of an impact is COVID. And so some of you may know that Melbourne was one of the most locked down cities in the world, and even though we delayed the commencement of our trial, we were still coming out of another lockdown when we did have to commence it. And then to make matters worse, we were in the thick of COVID vaccination, with many state-run immunisation facilities starting to ramp down and primary care and general practice being responsible for delivering more immunisations than any other part of the health service. So despite that, our experience and our results are not unique. So there's been another study recently published that showed no difference in quality of care outcomes for clinical decision support for diabetes in primary care, and the authors attributed this mainly to the way that the health system was organised and challenges with the electronic medical record systems. And I would say that we have the exact same issues in the Australian context. Now, we do know more broadly for clinical decision support that even if it is implemented and implemented well, many people still do not receive the recommended care. And in some cases, this is absolutely appropriate. There are people that shouldn't just be managed through the tick box of a guideline, particularly in the context of multimorbidity, but it does suggest that there's still a lot of work to be done. And this is where I'll come back to the learning health system and how we're going to be continuing to make iterative improvements and looking at the impact as well of different policy decisions such as patient registration starting to come in that might also impact some of these outcomes. So I did just want to make a couple of concluding remarks in that we can't expect changes in outcomes from introduction of technology if it's not accompanied by appropriate resourcing and health systems reform. So in general practice, GPs are only paid when they see a patient. They don't actually have dedicated time to be able to work on quality improvement. There's also arguments in some areas that, well, maybe we should just have a chronic kidney disease screening clinic and then a heart disease screening clinic and then a cancer disease screening clinic. But the reality is that people need all of those things. And it's countries with strong primary care that have better health outcomes, are more cost effective, and also, very importantly, are associated with higher satisfaction from patients themselves. And so I'm not here to say that general practice and primary care is the answer for everything. I do think we need to look at public health interventions and direct-to-consumer approaches to look at how we can improve broader knowledge, but also improve communication and coordination through different levels of care to try to get to the solution that we're all working towards. So I'll leave it at that. Thank you very much.
Thank you. Thank you.